down, then I guess I'll do it because that's the style here. I have no financial interest to disclose, and I'd like to talk to you about imaging of anterior segment lesions, the role of ultrasound by microscopy, and hey, when is it better to just do an anterior segment OCT? So UBM uses sound waves to image the anterior segment, as shown in this illustration, and UBM is an instrument that's handheld. I'm going to switch to a shorter version. I have a shorter version of this, which will make it easier. So UBM uses sound waves to image the anterior segment. ASOCT uses light waves to image the anterior segment. And basically, when we see patients with anterior segment tumors, if the patient has a tumor in the iris stroma, the pigment epithelium, or even deeper in the ciliary body, we tend to use UBM. It's best for those really darkly pigmented, deep tumors. Whereas if we have a child who might not be cooperative, we'll use ASOCT. Or if we're worried about infection where we don't want to put a cup on the eye, or the cornea looks thin, or if the lesion's in the iris stroma, cornea, and conjunctiva, we'll use ASOCT. So I generally tell the residents we use UBM when it's deep and dark, and ASOCT when it's superficial on the eye, and when it's light with little pigmentation. So these anterior segment lesions, the more superficial, we do ASOCT. The deeper ones, UBM. Sometimes we do both imaging modalities. A few years ago, we did an assessment of 200 cases of anterior segment tumors that were imaged with both UBM and ASOCT. And in this analysis, we found UBM offered better visualization of all margins and better images overall for the entire tumor configuration. Here I show you some examples. Here's an iris amelanotic melanoma with ectropion. And you can see on ASOCT, we get actually a pretty nice image. We can barely see the posterior extent, but on UBM, there's no doubt we can see the entire extent here, and there's no evidence of shadowing that might cause us to miss a deep margin. Here's one where ASOCT misses the deep margin in this pigmented melanocytoma, but on UBM, you can see the front and the deep margin. We prefer that for pigmented lesions. And another pigmented iris nevus, where the ASOCT shows the anterior surface well, but you can't see how deep this goes, whereas with UBM, you can see the anterior and the posterior extent. So for solid iris lesions, we prefer UBM to display all margins. And the same for iridociliary lesions. ASOCT shows the anterior contour, but if you look at the UBM, you'll see this lesion stops in the angle, has very little infiltration into pars plana, pars placata, and this bottom one, you can't even see how deep it goes, but on UBM, you get the entire configuration. Again, for iridociliary lesions, we prefer UBM over ASOCT. So let's just go into a few cases, and then I'll finish up. Let's look at some interesting cases where UBM or ASOCT were helpful. So this patient, case 1, comes in with this lesion right there. Suspicious for maybe melanoma, but let's dilate this patient, and we can see on dilation, maybe not melanoma, maybe it's a cyst of the iris pigment epithelium. So UBM shows it beautifully. We can see that it's a cystic lesion, no solid component, and ASOCT also was equally informative, in this case showing the IPE midzonal cyst. So for IPE cyst, you can use either UBM or ASOCT. I sort of like to rule out a solid tumor with UBM in such cases. Both provide fairly good, reliable images. Case number 2, an 84-year-old patient with an iris lesion, previously aspirated, now it's recurrent. So you can see the original lesion, now it looks a little bit bigger on the top. We get UBM, again, it shows the front and back margins, it shows the lateral extent. This is good imaging, but actually we get better imaging on ASOCT, beautiful imaging. We can see the front and back margins, and we can also see the quality of the fluid within it, and we can see septations within these cysts. And this is, of course, a non-contact ASOCT. So in these cases, ASOCT can, in many cases, be equivalent number 3, a 6-month-old boy with an iris lesion here, shown nasally. You can see an amelanotic mass. In this case, we got UBM because we were worried about a ciliary body component. As you can see, there were cysts in the mass suggestive of medulloepithelioma. And so, based on that, we treated this patient with plaque radiotherapy following fine needle aspiration biopsy to confirm the mass. Plaque was placed and the entire tumor was irradiated. Case number 4, 6-year-old boy, red eye, right side. You can see the red eye, but those of you who are really sharp might notice that there's a mass there in the iris, pushing the iris, causing accordion folds. We were a little bit unsure what this mass was. By UBM, we could see there was a solid tumor in the ciliary body, into the choroid, and dialyzing the iris. By standard ultrasound, we could see the mass also, and there is this amelanotic mass with a pars placata ahead of it. So in this case, we did needle biopsy, and this proved to our surprise to be Langerhans histiocytosis. So this lesion is super sensitive to low-dose radiation. We just gave a very low dose, and you can see before and after radiation, the tumor completely resolved. This here is the case of the century. This lady came in, she was 16 years old, she had a bad iris abnormality, and I was worried that this was melanoma in a 16-year-old, and I was worried that we might have to enucleate her. You can see her normal left eye and the affected right eye. So we got UBM that showed the iris thickened to 1.7 millimeters compared to 1 millimeter on the opposite side. Worried about melanoma, but we got ASOCT, and this is nearly pathognomonic. And Dr. Farouz knows what this is. It's an epi-iridic pseudomembrane on the iris consistent with JXG. She reported one of the first cases in a young baby, and we've seen others that have this. It almost looks like stalagmites reaching into the aqueous. So in this case, we did confirm it on FNAB as JXG and treated with steroids and didn't need to enucleate the side. It was only JXG in a 16-year-old. And then case number 6, ASOCT was favored here. Yeah, this is a young boy, 6 years old. We thought these were iris freckles. Here he is in 2007. We said, iris freckles, go home. Didn't even image him. He came back in 2009. They're bigger. We said, that's unusual. We imaged them. Yeah, there's a mass there. Maybe this is JXG in an 8-year-old boy. Well, we followed him, and 2 years later, they're even bigger. And the ASOCT showed them bigger. So at this point, with them bigger, we did fine needle aspiration biopsy. And believe it or not, this proved to be iris melanoma tapioca. Not one tumor, but there's 1, 2, 3, 4, 5, 6, 7, 8, 9, more than 15 tumors on this iris. You can see the tapioca melanoma even down here. So we had to irradiate the entire anterior segment. He's done okay. He's developed some corneal endothelial loss, and we tried to get him in to get DSEC done. But here you can see the plaque on the eye with the Gunderson flap, and you can see the tumor responded, but of course he developed a cataract, and then the cataract was removed, and the anterior segment actually was looking pretty good in 2017. This kid never saw a UBM. It's much less threatening in a kid to do ASOCT if you can, because that is non-contact. Now, no financial interest, but there is a new anterior segment sweat source, non-FDA approved imaging modality coming out. It is beautiful. It images ciliary body to ciliary body, and if you're dilated, it goes right through the lens. It's called Anterion, and it's from Heidelberg. We're anxiously awaiting the release of this imaging modality, because it can really, I think, really help those of us who deal with anterior segment tumors. So, in summary, UBM and ASOCT are critical to the assessment of the anterior segment tumors, and I think they're complementary. You know, I prefer UBM if it's ciliary body, deep and dark, and I prefer ASOCT if it's superficial, cornea, conj, or maybe in the iris stroma. Thank you.